Welcome to Gastrointestinal and Urologic Emergencies. So the National EMS Educational Competencies are for the Aemt to apply fundamental knowledge to provide basic and selected advanced emergency care and transportation based on assessment findings for an acutely ill patient, which means that you can recognize and treat within your scope of practice for that particular patient. Some of the things that we're going to talk about are the anatomy, the presentations, and the management of shock associated with abdominal emergencies, including gastrointestinal bleeding, acute and chronic gastrointestinal hemorrhage, peritonitis, and ulcerative diseases. We're going to be able to accurately and safely take a blood pressure assessment in a patient who is receiving dialysis, understand the anatomy and physiology, the pathophysiology, the assessment and the management of conditions or complications related to dialysis, urinary catheter management, but inserting and removing urinary catheters is not within your scope, and the treatment of kidney stones. So the key term that you're going to hear throughout this lecture is acute abdomen. And acute abdomen literally means sudden onset of abdomen pain. We're just kind of making it brief in our terminology, but understand that when we say acute abdomen, we are referring to a pain-like situation in the abdominal area or abdominal cavity. Some of the things that everybody needs to know is that abdominal pain is really difficult to identify. There are a lot of organs and structures within the abdominal cavity. So if you remember your anatomy and physiology, that's from the line of the diaphragm to the pelvic floor. And you don't actually need to really diagnose this. Most of the time, abdominal pain takes multiple avenues to actually really diagnose in the hospital, and that includes lab values and imaging of different sorts with the physical assessment. You should, however, be able to accurately recognize when somebody's in a life-threatening condition, and you should be able to act appropriately and quickly, which includes treatment and transport of your patient. So as we discussed before, the abdominal cavity contains solid and hollow organs. The solid organs include the liver, the spleen, the pancreas, the kidneys, and the ovaries. Injury to a solid organ can cause shock and bleeding. Solid organs in general have large vasculature. The liver has a massive blood supply in and out of it. The kidneys have a significant blood supply in and out of it. The spleen has a significant blood supply in and out of it. So I want everybody to kind of remember that any of those solid organs can cause a major, immediate bleed in a traumatic event. Here's a good picture of solid and hollow organs. If you're looking at your screen, which would be to my right while you're looking at me, we have the solid organs, which includes the liver, the kidney, the ovaries, the spleen, the pancreas, and the kidneys. Kind of understand where those things sit and where they're going to be affected if somebody has pain or has taken a traumatic injury. If you're looking to the other side, you have the hollow organs, which includes the gallbladder, the stomach, the small intestine, the large intestine, the ureters, the fallopian tubes, and the bladder. And in our case of the females, that's going to be the uterus. Ovaries obviously also being only in the females. While we're talking about the GI tract, we should absolutely have a solid understanding that the entire digestion process takes 8 to 72 hours, beginning with the salivary glands secreting saliva. The slide says that it's to help lubricate the food, but it also secretes particular enzymes which help breaking down the starches in your food. As we chew, we call this masticate. We're grinding and tearing the food up into smaller particles so that once we swallow it, it goes through the esophagus and ends up in the stomach. Now there's veins around the esophagus that are going to basically converge into a single portal vein. When we get into the stomach is full of hydrochloric acid. There's a thick mucus layer around the stomach for the stomach lining to protect itself against the acid. The stomach is capable of absorbing water, alcohol, and caffeine. Once we get into other parts of the organ system, we're going to dive over to the liver. The liver secretes bile and also filters toxic substances from the blood. It creates glucose stores and produces substances for clotting factors in the blood and helps with immune function. The small intestine, which is comprised of 3 parts, the duodenum, the jejunum, and the ileum, take enzymes and turn that masticated food, which is now called chyme, into substances that can be absorbed by the capillary beds that surround the intestinal tract. Try to remember the lungs and the GI tract are highly vascular and that's for a reason. It's because that's where we're getting nutrients and wastes exchanged, as well as oxygen and carbon dioxide exchanged. Large intestine, really for the most part, its sole goal at that point is to continue to move that broken down food, which is now called feces, out of the body. It's going to reabsorb as much water as it can while still allowing movement of the feces. And then there is some bacterial digestion, which will pick up the last bits of remnants and hard to digest food. The large intestine empties into the rectum, which is then emptied into the anus. Now, we're talking about things that do not have any kind of digestive system function. The spleen would be one of them. It's part of the lymph system. It assists in the filtration of blood. It also is a store for red blood cells in an emergency. Rolling forward into the genital system, we obviously have two sex or two genders, right? And that's male versus female. In the females, that is generally classified as ovaries, fallopian tubes, the uterus, the cervix, and the vaginal canal. In males, we have the testicles, the epididymis, and the vas deferentia, the seminal vesicles, the prostate gland, and the penis. Moving forward into the urinary system, we have the kidneys, which come into ureters that go into the urinary bladder. As that exits the urinary bladder, it goes into the urethra. As you can see on this, it's a male. And we have the prostate gland before it ends up in the urethra proper, exiting the external urethral opening in the tip of the penis. Part of the urinary system is really about two major functions. One is to regulate electrolytes and water content in the body. And it does this by the simple concept of water following salt. So if we have excess sodium ions, say somebody has a night of high sodium intake, right, table salt, the kidneys will filter that and it will pull additional water from the body to help flush that out. And then it's also aiding in the ability to regulate the acidity of blood, and it will excrete some of the waste and byproducts that will make metabolic acidosis into the urine. Also, the kidneys are a major source of where drug metabolites end up. So when the body uses a drug and breaks it down into other compounds, there are a vast majority of them that are excreted in the urine. This is why drug testing is done in a urinalysis, because a lot of the drugs that they want to test will show up as metabolites of a particular chemical in the urine. So as the day goes on, the kidneys can filter up to 200 liters of blood a day. This is a little bit of an exploded view. It doesn't get into crazy detail. This is a good picture of the kidney, and you have what amounts to be the renal pelvis, which is going to go into a ureter. You can see it in the diagram. You have the renal cortex, the renal medulla, the major calyx, and the minor calyx. These are all structures in which the kidney is comprised of, ultimately coming down to a nephron. The nephron is the functional unit of the kidneys. It is in the shape of a funnel, if you want to look at it like that. And that's where most of the filtering power comes from. Again, acute abdomen, just like I said earlier, when we say acute abdomen, we're actually just trying to be clever and a little bit short-winded about saying sudden onset of abdominal pain. Acute abdomen is indicating peritonitis, which is, if you're following along with your Latin, is inflammation of the peritoneum. The peritoneum is that lining around the abdominal cavity, and it has the ability to kind of sense painful stimuli. Peritonitis can be caused by infection, trauma, or any plethora of diseases that affect the abdominal organs. Partial peritoneum is the lining of the abdominal cavity. It perceives sensations. The visceral peritoneum is what's covering the surface of the organs. Really what we want to talk about on this is that all of these organs and the peritoneum that's around the abdominal cavity just allows all of the structures to kind of float amongst each other, touch and rub, without causing what we want to call an adhesion, which is scar tissue that tries to anchor something down inside the body. If we get adhesions, the internal organs don't have the free ability to move around, and it can be quite painful. Visceral pain is when receptors in the hollow structures are stimulated, and we'll get into this a little bit later, but we're going to talk about referred pain and those dermatomes. So remember that referred pain is a general sensation. That's that afferent part of the nervous system where it's sensing. Because the body actually doesn't have particular nerve receptors on those particular organs, we get what we call referred pain, and it's usually pretty distal of where that particular organ may lay, or it comes back to the nerve root, to the nerve that's closely related to the area where the organ is. Here's another picture on referred pain. As you can see there, you can see where the synapses are for the actual nerve. You can see where the gallbladder is. That inflammation triggers that particular nerve, and this gives us that referred or dermatome-like pain. Again, peritonitis. This causes ileus. It's associated with loss of bodily fluids into the abdominal cavity. So this could be anything from bleeding, bile, any kind of fecal matter, or anything that doesn't belong there. The abdominal cavity is sterile, and so when something else enters it that may be necrotic or have some kind of bacterial load with it, it will become inflamed rather quickly, and you may or may not have a fever, but it usually will present with a fever if that patient has a significant infection that's starting. This can present in patients with diverticulitis and cholecystitis, which we'll get into a little bit later in the lecture. Now, this is a common location of pain versus what the condition is. Now, this is not a hard and fast rule. Just understand that this is generally in association with, say, appendicitis, which has pain around the navel or the right lower quadrant. There's rebound tenderness, which is pain felt after you let off of the palpation of the abdomen in the site of pain. Cholecystitis has the right shoulder referred or the right upper quadrant direct pain. Ulcers are going to be upper middle abdomen or upper back area, right? That's going to be epigastric. All the way down to, say, hernia, which is anywhere in the abdominal area based on where the hernia is, or the peritonitis, which can be anywhere in the abdominal area as well. So what are the causes of acute abdomen? Really, any condition that allows foreign materials into the abdominal cavity can cause that peritonitis or the acute abdomen. I can't stress it enough. That's a sterile cavity. And as that infectious material or necrotic material comes into contact with those organs, it's going to cause inflammation, and it's also going to cause that acute abdomen or the abdominal pain. Pretty much anything that involves abdominal issues, trauma, or medical can cause abdominal pain. Now, we want to talk about GI bleeds because GI bleeds are pretty significant in a certain patient population. And one of the harder things to understand about GI bleeds is this is the hemorrhage that you can't see. For most intents and purposes, we're unable to see somebody who's bleeding into their GI tract. Unless you're there when they're having a bowel movement and there's significant blood in the bowel movement, or they have dark tarry stools, otherwise known as melena, or that coffee ground-like emesis, which is the digested or partially digested blood in the vomit, we're really not going to get telltale signs. And so the type of patient that we run into, they're going to look sick, and they're going to present like they're hypotensive, and they're pretty significantly sick. It's just because we can't see it. Far too often, providers will take it pretty loosely because they're not observing the actual bleed. Remember, this bleed can be just as significant as external bleed, and we need to take it just as seriously. GI bleeds can be very acute, either due to trauma or some kind of physical manifestation that causes a rupture, or it can be chronic, which is a slow progression of the particular symptoms where they're bleeding slowly over time, they become anemic, and then as this condition worsens, they become worse. It can happen in the upper or the lower GI tract, just like I gave the symptoms just a second ago. And then we can have esophagitis, which is the inflammation of the esophagus, and the effects are irritation and swelling to the esophagus, which is a very painful condition to have. While we're talking about the esophagus, we should talk about gastroesophageal reflux disease, otherwise known as GERD. And this is usually caused by the sphincter between the esophagus and the stomach not really having the tone that it once had, or it never actually had any tone, and it allows small amounts of stomach acid to move superior to the actual sphincter. That stomach acid, because there's no mucus lining on the esophagus, will cause corrosion and necrosis to that soft tissue in the esophagus. Ultimately, this ends up being what we call heartburn, and for it to be GERD, it needs to be persistent, where somebody's having frequent episodes of quote-unquote heartburn for several days within a month, up to every single day. Now, if this patient gets the stomach acid into the esophagus enough times or over a prolonged period of time, we can have what's called ulceration. These ulcers can ultimately end up bleeding, and it becomes a whole nother problem at that point. But we're going to talk about peptic ulcer disease and how this kind of works its way through the stomach and into the small intestine. The ulcers can be considered kind of like an abrasion of the small intestine or the stomach. In a peptic ulcer, the mucus layer is kind of dissolved or eroded away, and now the acid can actually get to the lining of the stomach, and by lining I mean the soft tissue, right? And remember, the stomach also has got a lot of vasculature around it because it's trying to absorb its own nutrients and waters and alcohols. The stomach acid will eat into that lining, and it will cause significant pain and sometimes even bleeding. This is usually as a result of pylori bacteria or the chronic use of NSAIDs, right? And that's your ibuprofens, your Tylenols, and the like. Heavy consumption of alcohol on a regular basis and smoking can also be a contributing factor to this. Now, peptic ulcer disease affects men and women equally, more frequently in older age groups, and that's, again, generally thought just because as we age, our body systems begin to kind of degrade regardless of how well we take care of ourselves. At a certain percentage per year, we can kind of stave it off a little bit, but as you get older, things tend to wear out and have less ability to rebound. Some of the symptoms of peptic ulcer is burning or gnawing pains in the upper abdomen or just below the sternum. Again, this is what we would call epigastric pain. Some of those symptoms are also nausea, vomiting, belching. Some of the ulcers will heal without an intervention, but then some of them require either medical intervention, like a surgical fix, or consistent medication to reduce the environment to allow the body to heal itself. Continuing on with the stomach and the esophagus, we're going to talk about a Mallory-Weiss tear, and that's a tear in the junction between the esophagus and the stomach. And the primary risk factors for this are alcoholism or eating disorders. And that's because we're allowing kind of the erosion of that tissue there, right? So when we're saying eating disorders, we're talking about bulimics or the persons who are tending to vomit up lots of food. The alcoholism obviously has its own effects on the GI tract. The vomiting is a principal symptom, and we can have bleeding that is either very minor or really severe. Next, we'll move into Boerhaave Syndrome, and this occurs during vomiting, similar to that Mallory-Weiss tear. The esophagus tears longitudinally, which means the up and down direction, so proximal to distal, and the tear travels entirely through the wall of the esophagus. This tends to occur more in men, and it presents after a large meal that includes alcohol. Continuing on with esophageal varices, the easy way to understand esophageal varices is if you've ever seen a varicose vein in, say, somebody's lower leg. A varices is literally just kind of a trapped compartment with a dilation of a small section of vessel that makes it pretty fragile and very engorged with blood. When this happens around the esophagus, the issue is that now we have a very fragile vessel that can empty blood into the esophagus itself and then secondarily into the stomach. So the amount of pressure that's creating this varices will increase and increase, and then initially the patient really doesn't kind of have any problems, and then suddenly we have some kind of a bleed, right? And so that's the patient will kind of show, in according to the slide, like the signs of liver disease, which is causing the backup because the liver is unable to filter at an adequate rate, and then that backup now creates the increased pressure into the vessels around the esophagus. And then as that vessel dilates and becomes kind of like trapped in its own section, it can rupture. This can be a true life-threatening emergency. Imagine just a heavy venous bleed that you can't see, and then you're not actually swallowing, but as you swallow your saliva, you're swallowing the blood that's actually entering the stomach as well as whatever's draining into the stomach as it is. And generally, most people wouldn't know about it until they've swallowed enough or had enough blood drain into the stomach that the blood becomes an irritant to the stomach itself. The stomach then will contract, causing you to vomit, and there's a significant amount of undigested and digested blood in your emesis. On the opposite end of the body, we're talking about hemorrhoids. And hemorrhoids is the same thing. It's like a varices, but it's right around the anus, and this is caused from intra-abdominal pressure. And this can be caused by anything. Women tend to develop these because of childbirth, from the bearing down to actually push the baby through the birth canal. Men or really highly active people may have this caused by simply just working out, and as they flex down on their core for their abdomen to brace for a heavy weight movement, they create the intra-abdominal pressure as well. People with regular hard like bowel movements that are bearing down on a regular basis because they're unable to pass fecal matter without much effort can develop this as well. The things that will tend to happen is that you will have a patient that is experiencing like a knot or a mass around the anus that's unexplainable to them because they're not aware of what the issue is, with some burning or itching sensation because of the nerves that are around that associated vessel that are now irritated as well. And in some cases, you can actually cause a small rupture, and then that person will experience some bleeding from the anus. A bit back more north, we're going to go into gallstones, and that comes from the gallbladder. Your gallbladder stores digestive juices and waste products from the liver, and there are some certain cases where people will develop certain mineral deposits in the gallbladder, which causes a gallstone. And as this deposit kind of calcifies and becomes a little bit larger, it can block the outlet from the gallbladder. It causes some pretty significant pain. Sometimes the juices will make their way through the actual tube, or the stone itself will actually make its way through. Sometimes the blockage is so severe that the gallbladder will just become enlarged, and then when it's not able to actually pass either the fluid or the stone, this is called cholecystitis. In rare cases that are pretty severe, the gallbladder can actually rupture, and this is no different than just thinking about somebody who has a backup of fluid somewhere and it's got to go somewhere. So at the end of this case, if they've got such a significant blockage that nothing's making its way through, it can actually burst inside the body. When somebody has some kind of gallbladder kind of disease process, the symptoms are usually right after a fatty meal, right, within the first 30 minutes. They tend to happen at night, and they'll have general kind of GI distress where they're just feeling nauseous. They'll have some vomiting, they'll feel indigestion, some bloating, and some gas and some belching. And a lot of the bloating and the gas and the belching is coming because the patient is unable to actually digest some of their food the proper way. And when certain parts of food make it into certain parts of the GI tract that they're not suited to digest, the bacteria in that part of the GI system will kind of ferment things, and then that's where the gas is coming from. Moving forward into pancreatitis, the causes of pancreatitis are obstructing gallstones, alcohol abuse, and things of the like. The results could be sepsis or even a hemorrhage in the pancreas. The signs and symptoms of pancreatitis are severe pain that often radiates throughout the abdomen and up into the chest. These patients will more often than not tell you that they have debilitating pain. They will be nauseous and have vomiting, and they'll have some abdominal distension because of where the pancreas sits. When it becomes inflamed, the abdomen will tense up and the inflammation will kind of show up because it's very high in the abdominal cavity, and they're going to have some tenderness to that area that may radiate throughout the entire abdomen. Now we're going to go a little bit south, and we're going to end up at the appendix. And for appendicitis, this can result in an abscess, peritonitis, or shock. And appendicitis is when the appendix, which is a small appendage off of the large intestine that's actually of no value to a human body anymore. Sometimes some food or fecal matter or other debris can actually get trapped into this small pocket, and as that ferments and kind of becomes necrotic inside there, the appendix becomes inflamed and can actually either end up bursting, which will empty fecal matter into the abdominal cavity, or become so significantly painful that it requires a surgical intervention. Most appendicitis cases start out as dull, diffuse pain. There'll be associated nausea and vomiting, anorexia, because the patient will not want to have anything that agitates that pain, so they're going to avoid food or water. They're going to have fever and chills because they are now actually kind of infectious with that particular part of the body having inflammation and infection. They'll have rebound tenderness. And again, that's when we push down on the abdomen, they're not going to have nearly as significant pain as when we let off suddenly. That rebounding is going to be more painful. Gastroenteritis is caused by bacterial or viral organisms. This is usually from some kind of contaminated food or water. So you can think of a handful of diseases that come from drinking like non-clean water, or if your food has some kind of bacterial load on it from poor hygiene or what have you. It can also be caused by non-infectious conditions, and those symptoms include diarrhea, abdominal cramping, nausea and vomiting, the fever, and the anorexia. Now, on this slide it says dehydration, and that's because the diarrhea is a significant portion of the symptoms, and diarrhea, evacuating fluid from the body in large amounts, will dehydrate even adults quickly. Diverticulitis. Diverticulitis is small pockets in the bowel that have kind of formed as a result of different changes in the way that we eat. So this slide says that it was first recognized around 1900 when the foods that people ate changed dramatically. And think about the Industrial Revolution, and where we were no longer dependent solely on lots of heavy vegetables and non-soluble fiber kind of food material. Modern kind of factory farming was starting to come into play, where we had lots more availability to meat, protein products, and we had a significant increase in the amount of bread products or starches that we were able to eat easily and cheaply. So the fiber consumption decreased, and then the consistency of people's stool is thought to have become more solid, and as that stool becomes more solid, the peristalsis, or the kind of quivering that the intestinal tract does to move feces throughout the body, needs to become more robust. And when we can't actually generate that, the pressure in the colon increases, and resultantly a small pocket will develop, and that is the diverticuli. These are small bulges in the colon wall, and they can actually trap or gather fecal matter, and then as that bacteria in the fecal matter replicates and grows, it will cause the inflammation. Now, a lot of people actually suffer from this particular disease process, and some of the signs and symptoms are abdominal pain, fever, malaise, which means general weakness, and body aches, chills, nausea, and vomiting. And in rare cases, there can be bleeding. You could think of this almost as like a tiny appendicitis. And some people can have dozens, if not hundreds, of diverticuli all throughout the colon. Moving into ulcerative colitis, this is caused by inflammation in the colon. There's really not a clear understanding of why we actually see this as a disease process, but the inflammation causes a thinning of the intestinal wall, which results in a weakened, dilated rectum. So think about what we're talking about there. Now, as that wall thins out, it's unable to maintain its kind of tone, and then it begins to dilate. This can cause all kinds of problems, and some of the signs and symptoms are bloody diarrhea. There'll be associated joint pain and skin lesions, and then there's mild to severe abdominal pain, fever, and fatigue. IBS, or Irritable Bowel Syndrome. This again is one of those things where there are many people that suffer from this problem. These patients have abdominal pain and changes in their bowel habits. There are three main factors observed in these patients. They have hypersensitivity of the bowel pain receptors, which I shouldn't have to really explain, hyperresponsiveness to the smooth muscles in the bowel, and then psychiatric disorder connected with the IBS. These problems usually start in childhood, and they tend to be lifelong issues. Crohn's disease is significantly more involved. It's kind of similar in the presentation to irritable bowel syndrome. This can involve the entire GI tract from the mouth to the anus. There's no definitive cause as of yet identified. It's thought to be highly genetic, and the way that it's actually passed from generation to generation. There can be many signs and symptoms that are outside of the GI system, and the disease results in a series of attacks by the immune system on the GI tract. So think of this as an autoimmune disorder. We're going to run through the pathophysiology of the urinary system, and these are conditions that range from UTIs, or urinary tract infections, to acute renal failure. In most cases, pre-hospital care is usually supportive. We can't really do a whole lot for these people, and you can basically treat some pain and give some fluids in the case that they need it. But in reality, the definitive care is either a urologist or a doctor to prescribe some kind of antibiotic, or to begin dialysis. So when we're talking about UTIs, we're talking about that urinary tract infection, and generally most develop in the urinary tract when bacteria enter the urethra and grow. It's more common in women, and that's because the urethra is significantly shorter in females than it is in males. In order for the upper urinary tract to become infected, the lower urinary tract has to go untreated. And so what we're talking about there is when we're looking at the urethra to the bladder and then the ureters. So if we have an upper urinary tract infection, that's the ureters coming up to the kidneys, which can actually cause a kidney infection, which could lead to kidney failure or acute renal failure with decreased kidney function. In a severe case, this can go all the way to sepsis, which ultimately leads to death if not treated aggressively and appropriately. The most common symptoms with a lower UTI is painful urination, the frequent urges to urinate, the difficulty in urination, and pain that begins as like a visceral discomfort. It becomes like a burning, kind of achy sensation in the lower pelvic floor. And then the obvious telltale sign is cloudy urine with a foul odor. Now when we get into kidney stones, I got to tell you right out of the gate, when you deal with people with kidney stones, this could be one of the most significant sources of pain in somebody's life. I will say out of my own recollection, I've had one event with a kidney stone, and it was debilitating to a point where I was laying on the floor, huddled in a mess on a tiled bathroom floor, unable to even move at that point in time. Now when I passed the kidney stone, that immediately stopped and my life went back to normal, and thank whomever I need to thank, I've never experienced it again. Kidney stones will originate in the renal pelvis, which again is that kind of hook shape going into the ureter. And when there's an excess insoluble salt or uric acid crystallizing in the urine, it will tend to build up. And these are usually measured in millimeters, and the inability to actually kind of get this to push through the ureter into the bladder and then eventually through the urethra is what causes the pain. So a lot of this can be tied back to insufficient water intake versus the particular salt that is decidingly creating the stone, which could be calcium, potassium, or uric acid. The calcium stones are the most common. They're more frequent in men. It's generally thought to be hereditary in nature, and they can occur in patients with metabolic and hormonal disorders. These patients are almost always in severe pain. And I'm telling you guys again, out of my own experience, I've never felt anything that was that terrible in my life. I hope that nobody ever has to feel it. And when I show up to a patient who knows that they have kidney stone problems and they look like they're in pain, I treat them aggressively for pain. There's no reason to let somebody have that kind of discomfort that is associated with a kidney stone.